So Michelle, we went through your initial treatment course really quickly, but I want to back up a little bit and just review something that is important for patients to consider. When you're making those decisions about the treatment plan, we made those together, but I was really giving my recommendations. I gave you probably 5 different choices to begin with. So currently, according to guidelines, there's a lot of different ways you can treat ovarian cancer. IV chemotherapy is the cornerstone of treatment. And you were treated with paclitaxel, carboplatin, and bevacizumab, which is an option. Another option is just the chemotherapy alone every 3 weeks. Or you can do this dose-dense approach where you do the paclitaxel weekly, you don't have a break. You can interject other drugs other than paclitaxel, such as docetaxel. Some individuals might use liposomal doxorubicin. And
I've heard of that.
then we talked a little bit about the intraperitoneal chemotherapy and which patients are appropriate candidates. So we didn't do intraperitoneal chemotherapy at the beginning because you weren't what's called optimally debulked. But after the chemotherapy and that second surgery, then you were optimally debulked.
That's when you put the port.
And that's when you put the port.
Yeah.
Exactly. But you know, that was confusing, right? So it's important for patients to know about their options. That was a long discussion we had in the clinic. That was probably 30, 45 minutes. And then we talked on the phone too.
Yes, and I went home and looked everything up online just to see what would be best for me.
Right.
And then your recommendations were spot on.
So it's all those different treatment options, what's right for you as a patient. Like I mentioned before, you were young and healthy, otherwise really fit. Somebody who's not as fit may not be as good a candidate for surgery. Then you need to think about other options like chemotherapy first to get them stronger, get the cancer under control, and then the surgery.
And then go back in.
Right. So and you know, that's a big question point too, is that do you do the chemotherapy first, then the surgery and more chemo, or do you do the primary debulking surgery first? And at Duke, how we like to make that decision is the laparoscopy procedure that we did in your situation. And then we said, okay, well, the reason, even though we can't remove it all, the reason we're going forward is just because you were so symptomatic. So that's a really important thing that patients should ask their doctors, which one's better for me in terms of the sequence? Is it chemotherapy first or surgery first? And how do we go about this? Any questions you had in terms of that whole treatment process? What were your biggest concerns?
I think my biggest concern is when I start hearing statistics. You know, they were concerning to me, like you mentioned Avastin. People with Avastin, statistically, how much longer do they live with it opposed to without it? So
you may not remember me saying this to you, but my classic line there is you have to be careful how you evaluate those studies because it's a number. And the patients that were on that study, they might not be just like you. So some of the other studies that were done with Avastin, they were done in women who had different types of disease. Maybe it was more advanced than in your situation. Maybe there was something different around the patient. So I take those numbers with a grain of salt. What you may remember, I presented them to you, but said, don't think about that. You as an individual, your story is going to be your story. So we don't know where things are going to be on that spectrum.
Everybody's so different. You just
right. And remember, that's a median number. So they give you this number that's in the middle, but there's a bell-shaped curve, right? And you could be on this long side of the curve, and that's what we're aiming for. You like that?
I like that curve.
Right. So I think that's important to know. And it's hard to bring up those questions about prognosis. Some doctors have a hard time bringing it up, and they wait for the patient to give the cue. But the patients don't always know how to bring up that question either.
It's a hard question, So doctors don't really know.
Right. And that's another thing with ovarian cancer. Some types of cancers, like pancreatic cancer, for instance, it's not as good of a prognosis. And most of those patients, it's a tighter period of time in terms of how long they're going to survive. But ovarian cancer, you can have women surviving anywhere from 24 months up to 10 plus years. It really has to do with their own tumor biology as well as their own medical issues that make that determinant and how well they respond to chemotherapy.